Good afternoon, everybody. This is Gene Ransom with MedChi, and I'm going to go ahead and call the meeting to order. I want to, first of all, thank everybody. I know that this is a very complicated and difficult time, and I appreciate the fact that so many of you have gone ahead and gotten online so we can keep the process moving. But I want to especially thank the Maryland Hospital Association and Pat for helping us, first for agreeing to host, and then once the hosting became impossible as a result of the governor's order and the CV-19 issue, to work with us to allow them to use their WebEx so we could continue to have the meeting and keep moving forward. Again, I'd ask that everybody keep their cells on mute unless they want to talk or say something. And I'm going to also let you know that we will, with regards to future schedule, I suspect our next meeting might also have to be a WebEx or a conference call as a result of the governor's order and the fact that we have so many government, both federal and state employees who are involved in this and they're required to telecommute. It just makes sense to do it that way, on top of the fact that we want to comply with the request that we make sure that this situation doesn't get any worse. And I did also want to take this second to thank all the government employees for all the work they're doing, both on the CV-19 issue, but also in helping us set up this new payment model. I think when you're working on things like this, you really realize how valuable government workers are and what they mean to us. So our goal with regards to EQIP is to continue on the timeline that's enclosed in the slides, and I'm going to let Chris go through that when he presents in a few seconds. And again, I want to thank everybody for participating, and I'm going to go ahead and turn it over to Chris so he can begin to do the slides. One last note, we are recording this, so you're all on notice. It is being recorded, and we're recording it so for those people who had emergent situations in their hospitals or in their physician offices and couldn't get on, they're going to be able to listen to the information at a later time. And I would also really encourage you to share this information with your colleagues, and if they have ideas or suggestions, it's very important that they reach out to myself or Chris or William as soon as possible so we can make adjustments, because you'll see the applications are coming fast and furious. Having said that, I'm going to turn it over to Chris now and let him begin going through the slide deck.
Thanks, Gene. Hello, everyone. This is Chris Peterson with the HSCRC. If you look at slide 2 in the agenda we're going to be going through, I will give kind of a recap on the EQIP design overall, update everyone, and talk about the schedule. For those who have been part of this process heretofore, it's kind of going to be old news for the most part, but we kind of want to do this in the case that new folks are coming on for the first time and make sure we're all on the same page. And then we're going to be introducing a new voice in this process. It'll be a voice with a British accent, and that is my colleague, William Henderson, who he and his team have taken the lead on getting way down into the weeds and the nitty-gritty on all of this, and so appreciate his leadership and the team. So we will be providing a lot of the details you've been asking for that we'll be teeing up here on this in this presentation, and then, as I will mention in a little bit, we will be releasing an RFI, a request for information, early next week that will also have some of this detail and want to get feedback from the field. But as you see here on slide 2, for year 1, we are going forward with 4 episode categories of orthopedics, cardiology, GI, and ED triggered episodes. What you will note, for those of you who have been following along heretofore, is that we have dropped oncology as a year 1 episode category and are adding emergency department as a new episode category. And the reason for that is the situation on the ground is really moving with respect to oncology. I think for the first 3 that you see here, ortho, cardio, and GI, it was relatively easy for us, and that's relatively easy in air quotes, to do those episode categories because we were excluded from them from the national models, and we could look to the federal BIPSI Advanced program to copy and paste and then tweak where we wanted to. With oncology, the oncology first model The feds are supposed to be releasing that any day now. And so I think all of us collectively want to make sure that we have the best information from the feds before we figure out what we need to do as a state. And so we have decided to put that on hold and maybe propose that for a year 2 category of episodes. And then, again, for those who have been following along, have probably heard Dr. Pines, who is an emergency department physician, has been wanting to move forward and has been talking for almost a year about having some sort of episode around emergency department physicians triggered there. And so we think there's a great opportunity to do this here in Maryland. And it's a great opportunity because this is a case where what can happen with the ED docs is in perfect alignment with where the hospitals are under a GBR. And I know that Dr. Pines has been part of a national association that's been trying to push this forward nationally. And I don't know, it seems like it may be a little harder to do nationally when the hospital's under a fee-for-service paradigm. But here in Maryland, and I say this partly to the hospitals and systems who might be on the line, I think all of these are just a great opportunity for you as hospitals to encourage physicians who work in your hospital, whether they're employed or contracted or whatever. I think these are opportunities that you can encourage those physicians to participate in some of these programs and figure out your role as part of that. So I wanted to mention that from the outset. As you see here, we have some appendices that get into some additional detail that we won't go over here today and walk through. So glossary CPT codes. I want to point you all to Appendix 2. Again, as we've talked about before, even though this is kind of new to us as a state to roll out an episode-based program with specialists, it isn't new to us because we've got the EQIP, the hospital convened program, so we're leveraging those internal capacities. But in terms of if you're a specialist or a physician group practice who's thinking about doing this, or a hospital system who's thinking, what's our role, that there are folks nationally who do this for a living, and we have asked them to provide information up to 10 slides that you will see in Appendix 2 along with their contact information. So from the state perspective, we are not trying to pick winners and losers. We're not trying to say who should be in or out, but we do want to create and make sure that there is a healthy market for conveners and folks who know what they're doing and do this for a living. And so I would encourage you all to look at those materials and think about the extent to which you want to leverage their experience. And then Appendix 3, there have been questions, particularly from hospitals and systems, about how this overlaps with other programs that the state has available. And so Appendix 3 goes into some of that discussion, which will also be in the RFI that we produce later next week. You will see an asterisk on almost every slide that this is all under discussion and negotiation with CMS, and so everything is subject to change. They haven't signed off on anything at this point because no documents have been signed, and so while we've been talking about this for months, even years, frankly, things are still in flux. And back to Gene's earlier point, I do want to note that our federal partners have been super, super engaged in this. They are believers in what we are doing under the Maryland model. And this, Gene has complained before, and I think rightly so, that there have been limited opportunities under the Maryland model for docs to really get aligned. But that is changing with the things that we have under the total cost of care model, and CMS has been working closely with us on that. So now skipping over to slide 4, again, the bad news has been that CMS has excluded the state from models that they do nationally. Some examples you see here on slide 4. But on slide 5, the good news is that now the Maryland model allows us to do our own thing in some of these approaches. One is the Maryland Primary Care Program, which started in 2019 in January. And here we're talking about EQIP. We are looking at an RFA to be released in the spring of this year with an expected start date of January of 2021. And then the rest of these bullets here on slide 5 are just to say that, heretofore the default answer from CMS about including Maryland in national programs, national models, has always been no. And now the answer is at least maybe. The reason that we have been excluded heretofore is because of the weird accounting interactions of our hospital global budget model. But if there's a model that really doesn't rely in a big way on hospital savings, then those are where CMS is trying to allow Maryland providers to participate in those national models. Going to slide 6, as a recap of the overview and goals of EQIP. EQIP is designed to help the state meet the financial targets of the total cost of care model. Those financial targets are focused on Medicare. Again, as has been alluded to before, both from hospitals and doctors, is the desire for non-hospital providers to be able to participate in these value-based frameworks. So this is another reason why we're doing this. And to encourage multi-payer alignment. And so even though EQIP is being rolled out as a Medicare model, as those of you who have been in prior meetings know that Care First is rolling out and has begun actually some episode-based payment models and other payers as well. So we continue to iterate with them. We want to have there be as much convergence as possible with other payers, and so happy to have those conversations. And then so the bad news has been we haven't been in CMS models, but the good news is that if we're going to do our own thing, then we can be more flexible, including adding more episodes than exist out there. And from the physician's point of view, is trying to broaden access to the macro opportunity of that 5% bonus. So all of these are great reasons that this is an important step for us to continue to work on. As with almost all Maryland model programs, somebody's got to take more than nominal downside risk. And as we'll talk about, this is the conveners in the EQIP context. So that's the big organization who's on top. The episode initiator are the physicians and other providers who can participate through a convener, and then it's up to the convener and those initiators and other partners to figure out, okay, if you, convener, are bearing the risk and reward, what's my share in that? And we'll talk about that in a little more detail coming up. Again, targeted start date of January 2021 with the spring RFA. But I think this is such an important point to note, is that under the federal model, again, this has to do with the trade-offs. Under the federal models, once you're in for 3 years, 5 years, whatever. And under this model, from a convener perspective, there's less risk in terms of you can sign up for 1 year, and, if it doesn't work, it doesn't work. Or if you're an initiator and you signed up with one convener, you can switch the following year. So there, again, from our perspective, we're just trying to create a healthy market, and we think that this is a great advantage for us to have. So it's moving to slide 7 and the different types of participants. In the rectangle are those who are essentially required to participate, if you will, and then those outside of the box are kind of optional participants. So there will be a participation agreement. That participation agreement will be signed by the feds, the state, and the conveners. And then the conveners have to have initiators who are working with them, but the initiators don't sign the PA. And then again, the conveners and initiators can decide whether or not there are these other optional participants. The optional participants are if the initiator happens to be a physician group practice, but then the physician group practice wants to share risk reward with the individual docs within that practice, then they have to execute and use this third participating practitioners bucket here. And then the sharing partners, again, this is optional for conveners. If, for example, you wanted to potentially share and sign up as a partner a post-acute facility as an example. So if you're working on orthopedic surgeries and orthopedic episodes and you want to partner with the post-acute facility, then that's why that arrangement exists there. It's not on the slide, and in the gory details that will come out from the CMS documents, there could actually be a fifth level that is under the sharing partners. And so if the sharing partner has individual docs or what have you who are under their organization and they want to share with, then that will be there. But anyway, just to note that all of this is built on not to create complexity, because frankly I wanted to avoid all of that, but it is to create flexibility. And if you're going to get flexibility from the feds, that often involves some complexity. So that's the trade-off. You'll see in the bottom left there's a note with a circle around it that acute care hospitals cannot be a convener, initiator, participating practitioner, sharing partner. Having said that, though, they can, participate as a system or an ACO or a non-ACH entity. I think, again, as I mentioned, hospitals can benefit from EQIP through retaining savings in the GBR for utilization reduction. So really hope that the hospitals, if not meaningfully participating or at least encouraging specialists and conveners to partner in this endeavor. Turning to slide 8, we get into a little bit more detail. I won't read through this, but the point is that the convener does bear the risk. It is a legal entity. The convener signs the documents with the feds and the state. We don't know how many conveners there will be, but there is no restriction on the number, and the convener will enter into an agreement, a written agreement with episode initiators. And the convener isn't just there to be basically a stopgap, stop-loss insurance company. The convener's job is to provide meaningful supports to those episode initiators. And so it is the technical assistance, care management, episode management analytics that you see there. And again, when you look at the slides in Appendix 2, you'll see what those folks have who participate in models nationally bring. Then slide 9 looks at the initiators, who are as Medicare calls it, the individual suppliers and providers who actually initiate the episodes and do the real work, if you will. They do not enter into the PA, as I mentioned, but they do enter into an agreement with the convener. So the initiators are the NPIs, and they must be vetted by CMS in order to participate. So I'll talk about this a little bit later on, but I want to tee it up here. That NPIs, the convener will submit to CMS a list of potential NPIs. And it could be the case that, an NPI is considering, well, do I want to go with convener A or convener B? And so the convener A and convener B may both submit to CMS a particular NPI for vetting. But once the convener signs on the dotted line of a participation agreement and says, this is my list of NPIs, my initiators who I'm signing up, then that initiator can only participate with one convener. So they can, explore for a while, be vetted as part of the initial process, but once it becomes real, the initiator has to sign up with a single convener and choose. Slide 10 then goes into a little bit more detail about these other arrangements that I alluded to earlier. Slide 11, I'm going to do, this is the 30,000-foot level. William's going to go into some much more detail about this, but just for those who are kind of seeing this for the first time, the idea is that the convener takes responsibility for the Medicare total cost of care. That's parts A and B. This is for fee-for-service beneficiaries. not Part D at this moment. And so episodes are triggered by primarily CPT codes and look at an episode duration of, by and large, 90 days, with the exception of the ED episodes that William will be talking about. So in this simplified example, let's say that the benchmark for the average total cost of care is $10,000 per beneficiary. CMS wants us 3%. That's the discount factor. So that means that the target price is actually $9,700. So if across the convener's patients, the average spending per beneficiary goes below $9,700, then the convener is going to get a payment for any savings below $9,700. On the other hand, if spending comes in above $9,700, then the convener will be required to make a payment to CMS for that cost. As I mentioned, one of the reasons we've been excluded from national models is because of this wacky global budget interaction piece, because the feds couldn't solve it or didn't want to solve it and have a one-off for us, which is totally fair. So we have figured out a way to do this. What we have talked about before is that we think we could only give conveners 50% credit for any net reductions in hospital spending. But as we've looked at the numbers and William's team has really dug into this, we think at this moment we're looking at giving conveners partial credit of 65%. So that is an increase from what we've been previously socializing. And again, there will be a stop-loss, stop-gain of 20%.
Hey, Chris, it's Nick Grosso. Good afternoon, everybody. Could you explain hey, Chris, the net decrease in hospital utilization? So does that mean a case that's normally done as an inpatient that is now done as an outpatient, like a total knee, will be subjected to the 65% credit? And yes, a case that's normally done as an outpatient setting, like a knee arthroscopy, will still get 100% credit?
Say that last piece again.
So, total knee replacements are typically done in Medicare patients as an inpatient right now, okay? So if we move them into an outpatient ASC setting, I understand that we'll get 65% credit for whatever the net gain is. But what about a case that we normally now do as an outpatient, like a knee arthroscopy? Will that then be 100% credit? Or will still be any Medicare patient, we're going to get 65% or whatever we saved?
It's 65% of the hospital savings. And William's going to walk through this in more detail, so this is just the 30,000-foot level. But so let's pause on that because it's a great question, and to your very good point, the numbers actually come out differently depending on which of those two scenarios it is. So let's pause on that, and William will address that specific point later on. So slide 12, we will be releasing an RFI. Gene will be sending it out through his email list. We'll be posting it on our website. That will go through additional details that we're talking about here today. And we really want to hear comments on the episode designs that we're talking about. We are not changing these 4 episode categories. This is what we're going with. But if you want to say, I would love to participate in this program, in these specialties, et cetera, then we would love to hear that as well. And the content of the RFI will be similar to what we're talking about today. And the due date for those comments, as you see, will be Friday, April 17th. So to talk a little bit about the schedule then on the next slide before I hand it over to William, on slide 14, just to talk briefly about the documents. Again, there will be an RFA that comes out in the spring. That RFA will have attachments and templates for conveners, potential conveners to fill out so that they can say, this is, yes, I'm interested in participating. These are the episodes I'm interested in. Yes, I, check the box. If asked to repay monies, if performance isn't good, I have the ability to do that, et cetera. So that detail will be in a template that folks will check, and to provide the template for potential episode initiators and other partners. And then CMS and the state will also provide the PA later in the year, along with an implementation protocol that will include the template for the final. These are the people who are actually going to be in this program. So then in response to those three templates and information, then the convener submits stuff. So that would be the completed application along with the attachment with the list for potential partners for vetting. And then at the end of the year, the signed PA and the signed implementation and the completed implementation protocol that will include the final certified list of folks who have been vetted and with whom the convener is going to participate with a written agreement between the convener and these partners. Going to slide 15, the left-hand side is just for those who follow BIPSI Advanced nationally and how our timeline compares. But on the right-hand side, you see that we are looking at a spring RFA release with the template for the vetting, and so that we can get the state can get the list of potential partners so that we can produce preliminary target prices along with other data to provide back to conveners. So that's another reason for us to get this information about convener, who do you think you might be participating with? We want to vet them, and we want to give you information for target prices and other data. So then the application will need to be submitted by conveners in the summer-ish. All of these dates are kind of subject to change, but this is ballpark. In response to that information, we, the state, will be providing a data flat file that William can speak more to that will include the target prices. It's actually not on the next slide. Then the PA will be available later in the year, and then conveners will sign it along with submitting their implementation protocol and their final certified episode initiators and other partners. So let me pause there before I turn it over to William in case there are kind of timing, process, broader policy questions before William digs into some of the details. Okay, then I'm going to turn it over to William to take it from here.
All right, thank you, Chris. This is William Henderson. I'm responsible for medical economics for the HSCRC, and we'll be working with Chris and team on putting together a lot of the detailed financial analytics and clinical analytics behind the program, and as we build that out. We'll also be working with, we have a contractor on board who has national experience, and they'll be helping us with a lot of the episode development and validation. And then we'll also be working with CRISP as we get into the reporting. So we can go ahead and go to slide 17. I'm going to talk about three big topics today. I'm going to go through the episodes that Chris mentioned in a little bit more detail and just share the numbers we have with that. Then I'm going to walk through all the various financial and design considerations that go into building the episodes and the pricing, and talk about where we are, what we know, and what's still to be determined there. And then I'm going to talk a little bit about next steps and the RFI and the data releases in the future. So we go ahead and move actually on to slide 18. So this is the list of episodes that are currently on the drawing board for year one. As Chris said, the four categories across the top, and then you can see the specific episodes below that. These are all going to be outpatient-triggered episodes. There's no inpatient-triggered episodes in year one, although we are hoping to include those in year two. So all of these are limited to outpatient events as the trigger. For the first three categories, they're typically triggered by relevant CPT codes. So they're event-based in that sense. The emergency department ones are triggered by an emergency department emergency department visit, coupled with a variety of other criteria that we will go through later. Moving on then to slide 19. This is a brief overview of how we built those. We are using the CCLF data feed we received from Medicare. The numbers I'm going to share with you are all from July 17th to June 18. We're obviously going to update those as we move forward, but for the initial grounding, that's the period we used. As I noted, the CPT code trigger that was used for each of them will be available in definitions. They're actually in the appendix to this presentation, and then there's also a separate handout that had them in another format with the descriptions. And then with the RFI, we will actually release an Excel file as well, so you'll be able to understand exactly which CPT codes we're using. Things I think we're interested in getting in the RFI is if you think there's any gaps or errors in the CPT trigger code that we're using in these definitions. Once we identify the presence of a CPT trigger, we do make sure it's ultimately an outpatient event, so we eliminate anything that is coupled with an inpatient stay in the trigger. Then we define the episode window. The episode window for all of these is 90 days, except the ED episodes. The efficient admissions one is 14, and the high utilizer one is 30 days, so those do run shorter episode windows. The rest are all 90. If within that episode window we see multiple triggers, we're going to use the first one. So if somebody triggers an ortho episode on January 1st and then a gastro episode on January 15th, the gastro episode is going to effectively get dropped, and we would only use the ortho episode because we don't want overlapping episodes.
But those costs would still be included.
The cost would still be included in that first episode, right? Yes, correct. Where we had a trigger that was a professional claim for a surgery, but we couldn't find a corresponding facility event, we dropped those. It's not a huge number. Most of the time we can find that. But if we only ever get a professional claim for some reason, then that would not trigger an episode on its own. It has to have a corresponding facility event, and that really is applicable to the surgery episodes, not so much to the ED ones, for example.
Hey, William, it's Nick Grosso for Centers for Advanced Orthopedics again. So, I mean, that's a significant problem. If I do a total knee replacement on somebody as an outpatient, and 60 days later they have a kidney stone and get admitted and incur a lot of expense, that expense go into my bundle, basically bust the bundle. We had the same issue with Care First and United, and they've somehow solved that issue where only the costs related to the CPT code in the 90 days following will be utilized for bundle numbers. Otherwise, there's no way we can control for that. A patient has a heart attack, 86 days after I do the total knee replacement, completely unrelated to my total knee, all the costs associated with that go against my bundle. The risk for us to participate in a bundle like that is too high. I don't think you'll find anybody willing to do that if you're going to include every cost that the patient incurs in the 90-day window post-op against the bundle.
Well, it happens now in BIPSI Advanced. I mean, this is the way that the feds do it. Which is why everybody nationwide. I just got back from the Orthoforum meeting out in Phoenix, and most of the Orthoforum groups are dropping BIPSI. They're dropping out because they're not able to win at it because of that. Well, this is something that CMS has essentially said is non-negotiable. That's number one. Number two is you are being held accountable to, relative to your own historical baseline. And so, to the extent that those costs happen within the baseline as well as in your performance period, and then, again, I think it's an advantage of being aggregated up to the convener level. I hear your point, and I understand that, but hopefully at the convener level, that doesn't overwhelm things. Okay. I think it's going to be an issue. Like I said, nationwide, from what I know from the large orthopedic groups, part of the Orthoforum, most of them are pulling out of BPCI because they're not able to win at it because of that.
This is Mike Weinstein. I'm with Capital Digestive Care in Maryland. Can you first, can you hear me? Yeah, I'm assuming yes.
Yeah.
Hey, Mike. Yeah.
Okay, good. So I had a similar question to Nick. So as a gastroenterologist, often we will see patients come in for a screening colonoscopy to be done prior to a hip replacement, because it's a lot easier to get the screening colonoscopy done before a hip replacement, right, Nick? As opposed to trying to do it afterwards with a brand new hip. We don't like to do that because of the infection risk. So if the colonoscopy is done first and then the hip replacement is done 3 weeks later, is the hip replacement part of the colonoscopy? Is it 90 days for a colonoscopy? Is the post interval 90 days for something as simple as a colonoscopy? Because in most of the bundle issues that we're discussing with the Prometheus model, defining the episode for upper endoscopy, for colonoscopy, the episode is generally 14 days.
Right, and we have the flexibility to dial that. So this is exactly why we're doing the RFI, and we want to get comments on both of these issues.
Okay.
Not to say that CMS is going to say, don't care, but I think it's important for you all to provide that feedback so that we can take that into account and share that with our federal partners and figure out, because, collectively we want to do the right thing here and totally understand the trade-offs that you're raising. And so to the extent that you provide that feedback, that can be very helpful.
And also for any of the groups, Chris and I are willing to do special meetings with Dr. Weinstein if you want to get some other GI groups together. We don't mind having a special meeting to understand issues specific to a specific specialty. We've done it for other specialties.
Yep. So I think to echo Chris's point, we would like feedback on exactly those kind of items in the RFI. Some of them are more negotiable than others. One thing I would say is certainly things that change the definition of what becomes an episode is perhaps more manageable than whether we include the total cost of care in the episode or not. So, for example, in the ED, there was some diagnosis code limitations put on it. So if you came back and said to us, we only think you could count visits that have episodes that have these CPT codes with these primary diagnosis, we can use that to change the definition of what's an included episode. Once it's an included episode, the current intent is to include all claims, but certainly, weigh in on that in the RFI. Continuing down the list here, Part D prescription drugs are not included. That's something we may look at for future episodes, but not in these year one. And then the last bullet point and what we've been talking about is to calculate the average payment for the episode. We're taking all the payments during the episode, totaling them up and dividing them. So that would include, quote-unquote, unrelated medical costs. There are a short list of exclusions that relate to more unusual things, but so that's certainly something we're interested in. If there's suggestions of things that should always be excluded, that's a potential. But generally, the principle is that the episode cost is the total cost of care during the episode window. Going to the next slide, then. So this is just to give folks a sense of the numbers here. There's one of these slides now for each of the areas. The top block is the planned year one episodes that are outpatient triggered. The bottom block adds in the related inpatient triggered episodes. And then on the right-hand side, we've thrown out some ideas of chronic episodes, typically that we don't currently have a process around, but we're interested in hearing more about. So that is another element of the RFI, is certainly if you have thoughts about which episode should be in year two and how to define those. But
hey, William,
yep.
I think you have the cost flipped for scopes and replacements on the knees.
We do, and I was about to. Yep.
Yeah, if you want to give me $18,000 doing knee scope, I'll gladly take it. But I don't think that's the plan.
As I was going through that today, I noticed that. So yes, the first line should be arthroscopy, and the second line should be the replacements. We'll correct that in future versions of this. Certainly later we're going to open it up if there's other thoughts on those, or if there's other ones where the average cost looks out of line to you, please let us know that in the RFI so we can investigate further. But hopefully these look reasonable with that correction. If we go down to the next slide, you get the same thing with the GI episodes. These are defined to 90 days, so if you think a more appropriate, shorter time window is appropriate here, please let us know that. Obviously, that would then reduce the amount of dollars in play, but would presumably increase the ability of the owning group to control that spend. If you go one more, you'll see the cardiac episodes that are currently in, just those two, and then the potential for the future. Quite a lot of other potential episodes on the cardiac side, so we're interested in getting feedback there. And one more slide. This is the ED episode, slightly different data here. Right now we don't have any year 2 expansions planned here. So what you see in the top block is a summary of the overall episodes. On the ED side, we are thinking that we will break the the efficient admissions, the first one, into some sub-episodes, so the total won't change, but because the different clinical presentations are included, we think we might end up treating them separately, and that will make the risk adjustment and other factors easier to handle. So you see in the bottom of the slide there is a breakout of the efficient admissions by the primary diagnosis that's getting included. We move on to the next slide then. So what we're going to walk through next is a bunch of the parameters that we're thinking about in terms of technically how we put the episodes together. So I think I will just move on to those. So we can go ahead and go to slide 25. So this starts with considerations around the payment, and what you see on here is just the overall element, different approaches that are being pursued by CMS, some additional thoughts about that, and then we tried to give you an indication of where we are. So in terms of the payments here, the base payment would remain through traditional fee-for-service. You would get paid for the claims as you submitted them, as would everybody else involved. We are not planning to do any capitated type rate where there's a block payment. The additional payment would be through the financial performance, so we're going to compare a target price to your actual payments. If you beat that target price by more than 3%, you'd get additional retrospective payments, and if you do not, you would owe money back to CMS. So that financial performance line is the primary mechanism that's in this model. There will be a quality adjustment to that. We'll talk a bit more about that later. We are not planning to use any of the flat fee type approaches that exist in some of the CMS models now. There'll be fee-for-service payment on an ongoing basis, and then a retrospective settlement based on financial and quality performance. There won't be any other new or enhanced payments. We go to the next slide then, please. So as we think about how we are going to set the target prices for that financial performance, I think CMMI has usually used 2 to 3 years of baseline. We have some limitations in data availability. We also have some concerns about going back 3 years in terms of its relevance. So I think we're probably leaning towards, we say 1 to 2 years here. I think we're probably leaning towards a 2-year baseline. And I think that would be for the first year of performance, which is calendar year 2021. The baseline would be calendar year 18 and 19. That's not set in stone, but I think that's probably where we're going right now. As we've talked about, it would be the total cost of care. There are some beneficiary-based exclusions. So first of all, it does only beneficiaries who have both Part A and Part B. I think for most cases, beneficiaries who die during the episode would be excluded. ESRD, there's a few others of special categories that we would plan to exclude on a beneficiary basis, and we're certainly open to input if there's other categories people should feel should be excluded as we think about the costs. Next item is, once we've established that baseline cost, in order to determine a target, we have to trend that forward for price trend. So we think of this in 2 buckets. There's the bucket that is paid in Medicare fee-for-service traditional, which is going to be the unregulated spending. So we will use information from price schedules to trend the baseline information forward. For the bucket that's paid through a regulated setting where the rate is set by the HSCRC under the GBR, we will use the GBR update factor information to trend that forward. We will not be using any regional or peer data to set trends. On the date of refresh, I think there's been some considerations about in thinking about the baseline, how old should the baseline data be. We are, as I said, going to use CY19 will be the end of the baseline period. As I said, I think most likely it will be 18 and 19, but that isn't definite yet. But it won't be anything more recent than 19. So 20 will sort of be a period we trend over, and then 21 will be the performance year.
So, William, again, it's Nick Rosso. Again, the trending is a concern, and I'm not real clear on what this means, because the fear is any kind of bundled programs are race to the bottom. The more successful we are going forward, the lower our target prices are going to get. Is there a trend upward based on inflation or consumer price index or anything like that? Or are we just going to keep us seeing decreased reimbursements going forward?
So the target pricing would be an inflated baseline. So we're going to track using whatever additional payments Medicare is making and what payments we're making on the GBR in terms of price. So if the reimbursement on a per unit basis was $100 and now it's $102 and that's a 2% trend, then we're going to bake that into your target. So you should be whole for pure inflation. We are also not planning to move the baseline period forward for at least 3 years. So if you achieve savings in year 1, in year 2, you're still being compared against the same baseline, just with the additional year of inflation. So we're not baking in reductions you've achieved and then holding you to beat those reductions. Does that make sense and answer the question?
Yes. Yep. Thank you.
And we actually have more on that. I think if we can go to the next slide, that might be more on the next slide.
And William, you see that there's a question in the chat as well.
All right. Let's see.
It says, does the target price for 2021 include only outpatient costs from those years, or if the procedures were primarily inpatient, does it include inpatient?
It would only include outpatient procedures from those years, because we're going to basically define the baseline costs in the same way we define the performance period costs, and those are inpatient. Sorry, those are outpatient. Going on to this slide then, the discount factor, I think we've talked about this a lot, is 3%. So basically CMS gets the first 3%. There aren't any withholds, not really applicable here. In terms of setting that baseline, it will be the participant's own historical experience. So you will have submitted a list of NPIs. We will go back in time to the baseline period, run the same episode definitions for those NPIs, and that will become the starting point for determining your target price. We will not be blending in regional experience or building in any efficiency factors. The only situation we may have to use regional experience or state averages is if we've got a small cell that we need to get some significance to set the target in. But generally speaking, as long as there is enough information in the baseline quantities, then that's what you're being measured against is your experience on the same set of episodes in the baseline period. We go down to the next slide. As we said, geography, we're going to start with the actual payment rates in the history, and then we'll trend those forward. In general, we're not doing, CMS does some standardization around geographic differentials. We're not going to do that because we don't think it's necessary. In Maryland, however, the one thing we will be doing is within the regulated claims, because during the year the hospitals do a bunch of monkeying with their rates based on what's going on with their GBR. So you can get some sort of fairly strange changes in the price of a specific procedure. We'll basically be looking at we'll reprice those claims at a standard rate order for that hospital, so that you're not subject to the sort of variations in that the actual payment. You'll be getting the rate that they paid during the during the year in the standard in their standard rate order. It will be done by hospital, though, so to the extent different hospitals have different rates, that would factor into the comparison. So if you end up shifting units from between hospitals, then that would be part of your scoring as the difference in those hospital rates. But during the periods, those rates will be held constant at an individual hospital. We will be taking out the low and high outliers, and then we will be accounting for the GBR feedback. I'm going to hold this. We've got a slide in which, as Chris said, we went through this and tried to show the different examples and the implications of this, because it does have important implications, and we wanted to be very clear to potential participants about that. So we'll hold
William,
that.
is that 99 and 1%, is that the same as BPCI Advanced?
I believe it is.
I thought they used 2 standard deviations above and below.
Yeah, I don't know, Chris, or if there's somebody else who knows off the top of their head the answer to that question.
Because if I remember my math correctly, 2 standard deviations gives you a 2.5% tail above and below.
Right.
And it doesn't, 1.5%, if 1 or 2 cases falls into that margin, it can really skew results.
Windsor Rising and BPCI Advanced is at the first and 99th percentile, so we're copying that.
So it's the same as BPCI Advanced, okay.
Yeah.
Thank you, Chris. So we go ahead and go to the next slide. So I think we've kind of walked through the target price approach now, but basically we'll look at the same experience for your NPIs in the baseline period. We will then update it with those price trends based on Medicare fee-for-service rates for unregulated spending and based on GBR trends for regulated, and then we will adjust the case mix based on an acuity index so that the performance, so that the target price reflects the same acuity as the performance period. We'll talk a little bit more about the process there. Price cells, that relates to the risk adjustment. I'm going to hold off on that and talk more about that on the next slide. Reconciliation, this is another area we're interested in feedback on. So I think, generally speaking, right, we're going to, once the episode is over, there will be a run-out period, 180 days, something like that. We'll then calculate the costs, and that's the basis on which any payments are settled. Whether we use 180 days or 365 days, and whether we do a preliminary settlement and then a final settlement is still TBD and is something we're interested in getting more feedback on. We want to balance trying to get payments and settlements out to people in as timely a fashion as we can, but we also want to avoid too many complex overlapping reconciliations, and we also want to make sure we're using enough run-out that it's a fair answer. Go on to the next slide. So now we're into some of the risk-sharing and mitigation strategies. This is a two-sided model as required for this model. It is voluntary participation, so certainly, that's the way we hope people don't choose, but ultimately, if you believe you can handle the risk, there isn't a mandatory requirement here. There is a stop-loss, stop-gain that is 20% of the target price, so gains above 20% and losses above 20% would be taken back to CMS. And then we did notice already that we are planning to take out the extreme outlier cases. We go on to the next slide.
Gene, really quickly, is there any wiggle room on the stop loss? I mean, that's a big number. Is that a pretty firm thing from CMS on the downside risk?
Yeah, I think, Chris, they have been pretty firm about that one. Am I correct?
Yeah,
in that?
they have. That's actually also copied from BPCI Advanced. To be honest, I think there's probably greater opportunity for stop gain than stop loss, but that's just my own opinion. So, but yeah, I hear you.
Yeah, the only issue is that obviously when you put the stop loss at such a large percentage, you limit people being willing to take risk. So some folks who might be willing to do it aren't going to jump in, so it might limit experimentation. I just think it's an important point to make to CMS as we move forward.
Yeah, and again, I think that's why if you look at one of the other federal models like the oncology model where it was the practice who was taking the risk, and there you're definitely right, but one of the complaints about OCM is that it didn't have a convener role. In fact, there was a paper in Health Affairs that said this is one of the big failures of OCM. It didn't have a convener role, and so hopefully the convener role here, kind of spreading that risk, and the convener choosing who they think can be successful, et cetera, can help mitigate that. And again, the convener decides what level of risk and reward the individual practice or initiator bears. So I think those are important design elements.
And this is Mike Weinstein at Capital Digestive Care. You know, we're working on a similar program with Care First. It seems to have a lot of parallels. But to echo Gene's comment, jumping in at 20% without understanding completely the up or downside seems to be a big jump to get started, to understand how to do this and understand our risk. So I would echo Gene's comment. It would be nice to see sort of a staged risk thresholds, maybe starting at half of that in the first year and advancing to 20% in the second year, in case we get our lunch handed to us. So,
hey Mike, I could speak to that because we've been doing BPCI Advanced in Virginia with our Virginia groups, and the way it works with the convener is the convener will take some of or all of the risk, and it just changes the amount of money that they would keep on the upside. So right now, in our first year of BPCI Advanced with our convener, who's Fusion 5, they are at risk for all of the negative if we go negative. But because of them accepting that risk, we give them a bigger piece of the upside. So the risk modification will happen at the convener level, not so much at the model level. So that's how we're handling it with BPCI Advanced in Virginia.
So you're able to offload some of the risks to some other entity.
We've chosen to offload all the risk, and we've given the convener a much bigger piece of the upside because of our worry of we weren't sure we were going to be able to be successful because we don't have a whole lot of people in Northern Virginia. It was a relatively small set. We've been able to do okay, so it hasn't been an issue. But yes, we were able to offload all the risk. Now, going forward, if we want to start accepting more of the risk, then we get a bigger piece of the upside.
Yeah, which is fair. That's what I'm saying. You'd like to start with a little bit. I would accept a little less upside for a little more safety on the downside. I agree.
So this is Gene again. I think this is a really important issue because one of the issues is we're doing something that's very specific to Maryland. And Dr. Grasso, you're working with a national organization. Hopefully they're going to be willing to take risk here in Maryland. But for some of the other specialties, we need to see if some of the partners and maybe the partners who provided us the information is in the appendix. Maybe some of them will be willing to take some risk. But we just need to make sure that there's somebody there who's willing to do that so the program will actually work. Because one of the fears I have is that we create the thing and it's a really good idea, but the business model doesn't work, and then no one does it, and then CMS is mad at us. So maybe we can parking lot this and have a longer discussion about it in a subgroup, but if we don't figure this piece of it out, the program might not work.
Yeah, I mean, I think from a state point of view, we are, definitely interested in hearing things that you think make it work. We recognize there is risk here, and that's certainly some of the reasons for bringing in the convener role and making sure we include that. So I'll continue while we're talking about the risk. So the other thing we will be doing that also should help mitigate the risk to some degree, so we will be doing a case mix adjustment. I think we're still working with our contractor on exactly how we'll do that, but we'll rely on most likely some analysis of HCC scores. What I illustrate later is a fairly simple multiplicative adjustment, but we'll be looking at that and trying to make sure that the statistics all work in terms of the the risk score capturing the acuity of the patient. That clearly isn't, perfect protection against outlier cases, but is additional protection against shifts in your overall patient mix over time. So this just goes through some of the things, age and gender, APR, DRG, et cetera, dual enrollees, some of the factors we'd consider in adjusting the risk over time. We can go to the next slide. So we've now moved out of the parameters of the model. Hopefully that was helpful. This slide was our attempt to capture, I think, one of the most important things about it, which is how we are handling the GBR offset. So what this slide has across the top is 4 different scenarios of how savings might be generated, and then we're going to walk through in a simple fashion the impact on the savings. So the simplest one.
And Nick, sorry, I just want to say, Nick, this is exactly the thing that I was delaying for till we got to this point, because I think this does a good job of explaining. Okay, yeah, you moved $1,000, but what does that mean? And so this makes it pretty clear what the trade-offs are, because it's not 100% across the board. It's different based on the setting. So this makes that point.
Okay, thanks.
Thanks, Chris. So this first column here is the simplest one. So this assumes that you eliminate costs in the unregulated setting, so maybe a post-acute stay, and you generate $1,000 of gross savings. There's no offset because those are all regulated. They're all unregulated savings. So your net unregulated savings is $1,000, and that drops down. CMS would get their cut, but there's $1,000 to play with. The second scenario is where you eliminate $1,000 in the regulated setting. So maybe you're eliminating a readmission that otherwise occurred. So again, you have $1,000 of gross savings before offset. Your net regulated savings is $1,000. Your net unregulated is $0. So we take that net regulated savings of $1,000 and we take off 35%. So you get to retain 65%. So that means $350 of the $1,000 effectively goes away because that's getting pushed back through the GBR reset mechanism to Medicare. So we don't count it as savings. So your net savings in this case, although your gross was the same, because they're all unregulated, your net is only $650 in this case. And then CMS would still get their cut of 3% based on the original target. So those are the simplest scenarios. So the next scenario is you're in a regulated setting, but you shift to a cheaper regulated setting. So you end up moving, I think the obvious one here is you move from hospital A to hospital B. So your gross savings is what you eliminate. So you eliminate $1,000 of cost at hospital A, but you have new costs because this procedure now exists at hospital B. They're a little bit cheaper. That new cost is $800. So again, you have no unregulated savings in this scenario. You do have $200 of net regulated savings. That's the amount that you apply the GBR discount to. And so you, in fact, lose 35% of the $200, which is $70. So you end up with net savings of $120 in this scenario. The last scenario, and the one that, to be honest, is most significantly impacted by this GBR discount, is where you move things from a regulated to an unregulated setting. So you have a $1,000 procedure at a regulated setting. You have gross savings of $1,000. You then offset that because that procedure now occurs in an unregulated setting where it costs $650. So now when we look at the net savings by place of service, you have net actual negative savings in the unregulated setting of $650, and you have net regulated savings of $1,000. And it's that net regulated savings that gets the discount applied to it, so you lose $350 of that $1,000 of savings. And then when you add that up, you've got savings in the unregulated setting of $650, savings in the regulated setting, adding the last two rows together of $650, and you effectively have no savings, and CMS still gets their 3%. So in this scenario, the convener would be out the 3% in effect. So this is the scenario that clearly the mechanics of the model penalizes the most, because basically you're taking a discount where you get the savings, but you're not getting the benefit of any change where you get the dis savings. We purposely chose 650 here because that's kind of the break-even point. If that unregulated setting was below 65% of the cost of the regulated setting, this would still, if we drop those numbers through, this would still generate savings. If that unregulated setting is more expensive than 65% of the regulated setting, then this model would actually net to negative number. So I'm going to pause there and see if there's questions.
Well, yeah, that raises a lot of questions. So
yep.
If I take a total knee replacement that I would normally do as an inpatient, which is a regulated space, and there's a rate set to that, whatever hospital I do it at has a rate set, and I do it in a ASC, which is an unregulated space, you're telling me I'm not saving any money? I'm going to come out with zero?
Well, right. Well, so first, you can't, in this model, you wouldn't be going from inpatient because it wouldn't include inpatient. But if you've done the same thing with outpatient, we're saying yes, that effectively, because of the GBR mechanism, Medicare isn't saving money. If you're less than 65%, if you're 65% or more at that unregulated setting. So if you move it from a hospital outpatient to an ASC, and the ASC is more than 65% of the cost of the hospital outpatient, the mechanics of the model are such that that does not score savings.
This is Steve Michaels. I just wonder if the second to the last column, regulated to cheaper regulated, if a scenario of that would be, the patient was previously an inpatient for a total knee, and then became a, same-day surgery for a total knee. Is that a similar kind of savings for regulated spaces?
That would be how the mechanic works if inpatient was in the model. Yes, but inpatient's not in, so that scenario wouldn't be included in the baseline.
So this is Mike. So that means the outpatient, in Nick's example or in our example, moving a patient from a outpatient hospital setting for a procedure, colonoscopy for me, gastroenterology, to an ambulatory surgery center. If it will only work if the total cost at the ASC is less than 65% of the hospital outpatient facility. Is that right?
Correct. Yes, that is correct.
That's quite a disincentive.
I think unfortunately it is. We recognize that, and that is why we wanted to make this very clear here that people didn't misunderstand that. But that is effectively the mechanism because of the GBR feedback and the way that works, and the fact that the hospital retains a lot of that revenue even as you move it out. The savings aren't what they would be under other reimbursement systems.
So the price
in the chat, just so you see it. Go ahead. I'm sorry, Dr. Grasso.
So the price that you had earlier for a total knee replacement was $18,000 and change. Is that the regulated price? What is that price?
Yeah, that is going to be the average price across all experience, so regulated and unregulated. So
I have to bring my cost to 65% of that in order to realize any gain whatsoever?
Yeah, so we assume that 18 was the regulated price, and I think most of those are still unregulated. Then yes, effectively, if your unregulated price you'd have to bring it to 65%. All else being equal, right? Assuming that there weren't other savings opportunities.
But only unregulated outpatient.
Sorry, I missed that question.
But only unregulated outpatient.
Only unregulated outpatient.
I mean, when you talk about regulated, it's regulated outpatient stuff, not inpatient stuff.
Right. Regulated outpatient to unregulated outpatient.
So in this model, in this model, I would have to do a total knee replacement for 65% of that $18,000 number or less in order to make any money. plus I'm responsible for every cost within that 90 days, including the stuff I talked about earlier. If a patient has a heart attack or a kidney stone, those costs get thrown in. Again, I still have to be 65. Yeah. This model's not going to work.
William, I'm not sure that's right with respect to the 18,000, because am I right? The 18,000, that included all costs. So that is physician costs, everything in the total cost of care, correct?
Yeah, I mean, I think it is probably technically not right in the sense that, yeah, the 18,000 will also include in the baseline if people had, other had a heart attack or so on. So the 18,000 is not, as you say, Chris, the true regulated cost. Right, so it'll be something south of that.
Right, it's not clean. It includes all the average complication, avoidable complications as well.
Right. Plus the
but then those numbers need to be broken out. It has to be, two numbers have to be in whatever the price is, what the regulated price is, and then what the additional cost is anticipated to be. So if in that 18,000, exactly right. If 10,000 was the regulated cost, then we have a target that we have to beat by 65% or less, and the other stuff we just have to be on par with.
Right. Or if you can generate savings in the other stuff, then that helps make the model work.
So I think this slide shows multiple things. One is that the far left is where the opportunities are. But to your point, Dr. Grasso, that's exactly why, from our perspective, we want to figure out how we can provide essentially the information that you're looking for, which is, okay, if I'm looking at the effects of essentially the right-hand two columns, I need to know what the price point is for those services in the regulated facility so that I know essentially what I'm being held accountable for. And to William's point, the way that we will do the methodology is to fix the price, that price will essentially be fixed in advance. And so to the extent that we can elucidate what those numbers are, I think that can be helpful.
So quickly, Jennifer asked a question in the chat. I think there is an impression that inpatient moving to outpatient is in this model. Is it in year 2?
Yes, inpatient-based episodes and inpatient to outpatient would be in year 2 as we're currently thinking about it. That, I think, is not definite because CMS hasn't signed off on that, but that is our current thinking.
Right. So in your example, William, we're talking about outpatient triggered episodes. And so for your third column of numbers, it's moving from hospital A to hospital B for something that's currently in the hospital outpatient to something that's in the hospital outpatient, not triggered in the inpatient setting. Right. And then the last example is moving from something that's triggered in the hospital outpatient department to something, for example, that's in an ASC.
Right. But to the earlier question, that third column is equivalent to what happens if you were talking about year 2 and you were doing inpatient, outpatient at the same hospital. The mechanics are the same in that scenario.
Yeah.
And I think one of the questions we have in the RFI is about what additional data, folks. We certainly weren't thinking that the one number was sufficient for decision making. So that is something we're interested in getting more input on. Any other questions on this slide?
Jennifer, she noted having the cost breakdown by setting would help SNF, outpatient rehab, procedural costs, et cetera. And I think, William, in the data file that we would be providing, that would definitely be in there.
Correct.
And then follow-up is in year 2, would conveners get credit for moving something from inpatient to outpatient and those savings, or is it every year only moving from like setting to like setting?
And no, we would give credit for that. So we're very much viewing this as site neutral. So the baseline is based on the average of the historic mix, and then the performance will be based on the average of the new mix. And if you save money through shifting, then you'll benefit from that.
This is Gene again. I just want to reiterate that a lot of physicians I've shown this to have expressed concern about the percentage discount related to the GBR, and I do appreciate the fact that you guys have increased it to 65 from 50, which it was originally. But maybe because, and I understand the reasoning why you have to do it, but maybe when we're dealing with CMS, we can have a discussion about changing the stop loss as a result of that, because this really does add another level of risk that other states don't have to deal with, and that might be an argument for why maybe they could be a little more reasonable on the other one.
Yep, that could be something that you submit as the comment letters.
And you see that Justin asked, would agree with the cost breakdown question, would be curious which data elements are in the flat files and whether CCLF raw claims could be requested.
So CCLF raw claims will be available, but only after we have assigned participation agreements. I don't think we're going to be releasing those in terms of people deciding to participate or not. It will be the summarized claim.
And to say it in other words, we've gotten what CMS provides in a non-PHI format. And so to William's point, while what we would be providing to potential conveners would not be PHI, we want to be sure that it has enough of the elements. And so we will try to share what the contents, the variables in that file could look like, and try to do that sooner rather than later.
I think the other thing we could probably do much sooner is release a new version of those slides we went through with a little bit more detail just at the aggregate level, so people can get a better sense for how much is regulated and how much is unregulated. We already have some of those, and how much is in SNF and things like that. We already have some of those breakouts, so I think that would be easy enough to do.
Thanks.
All right, so we'll go ahead and, since we've made everybody happy with that slide, we'll go to the next one. So this slide works through in a little bit more granular detail the exact mechanism of the savings calculation and the differences between regulated and unregulated costs. I'm going to go through this fairly quickly because I think it's really something that makes more sense for folks to digest offline and then ask questions than try and do it live. So basically what we show here is you start off with a baseline period and you calculate the average episode cost in the baseline period, and we've shown it split between regulated and unregulated costs. That isn't necessarily where the episode would be initiated, but that's the costs in both, because it's certainly, you could have an unregulated episode that starts in an unregulated space and has regulated costs and vice versa. So it doesn't matter so much where it starts, but where the costs are accrued throughout the episode. So this example is 10 episodes with baseline costs of $150,000. We go to the performance period. As it happens, they also have 10 episodes in the performance period. This would, that we just made to keep this simple. All the payments would be based on the actual number of episodes in the performance period. And those 10 episodes only cost $135,000, but the assumption is that there was some additional shifting. So you'll see is we've shown the regulated costs going down, but the unregulated costs going up a little bit. And then the other key piece of information is the case mix index. So there's been a small increase in acuity from the baseline to the performance period. This example uses a simple multiplicative impact. As I said earlier, we'll be working through the exact risk adjustment methodology. All right, once we kind of know our inputs then, we need some other information. We need those average price trends. So this obviously comes from a whole bunch of sources, but in this example, we said the regulated average price trend was 2 points and the unregulated was 3 points. And there's 2 years between the baseline period and the performance period. So in this example, we're saying it was a 1-year baseline of 2019 and a 1-year performance of 2021. That's 2 periods in between. You then take those baseline costs of $10,000 per episode in the regulated column. You trend it forward based on that inflation for 2 years. You get to $10,404 as the trended baseline costs in regulated and $5,305 in unregulated. We then adjust for the case mix, which we're doing here, just that ratio of 1.01 over 1 times the 10,404. So what that's saying is if the baseline period after trend and case mix adjustment, if nothing had changed, we would have expected the regulated costs to be $10,508 versus the actual of $8,000. Then the next step we show on here is that CMS gets their 3%. So that is 3% off the 10,508 and 3% off the 5358. So CMS gets 3%, and that gives you your target price. So amounts below that target price, the convener gets to share in the savings, and above that target price is where they would pay back. And then we show the impact of the GBR offset. So we started here, and unfortunately there is an error in this, and we're going to send out a new version as an update. So we said your net regulated savings were $2,193, which is the 10,193 minus the 8,000. That is the net regulated savings to the convener, but it's not the total net regulated savings because it already backs out CMS's share. So when we go to the next line, that line that takes the GBR discount off should be applied to the net regulated savings before CMS's share. We, in error in here, applied it after. So we'll send that correction out, and then that will be the version that I suggest folks work through to make sure they understand this. So that is 767 correctly goes up to like 878 or something. You don't have any of that in the unregulated column because there's no GBR offset in the unregulated column, and then you add those numbers down, and it gives you the savings per episode to the convener. So they have a positive savings on regulated and a offset in unregulated to net savings of $1,122 per episode. There was 10 episodes, so their total savings would be $11,221. And then the one other adjustment that would go into this that we don't show on here is that there is a quality adjustment, so that payment could be adjusted based on quality performance. And we'll outline more about that later. So that's the overall savings calculation. I'll go ahead and then go to the next slide if there's no questions on that. So the quality measures, we have to have quality measures for this to qualify as an advanced alternative payment model. So basically, there'll be a set of measures, and that final payment will be adjusted based on quality performance. There's going to be some measures that will go across all of the episodes, and we've referenced the MIPS measures there. There may be others where we think there's something that's appropriate to a specific episode. So something like the complication rate for total knees would be an example of that. So we're going through now and looking at measures, and one of the next meetings of this group, that will be one of the primary agenda items is what measures make sense. Go to the next slide. So we've talked about a number of these things. Just wanted to hit what we think would be in year 2. Inpatient-triggered episodes. We want to look at, I think everything we've got on here is sort of event-triggered. Are there chronic episodes that make sense? And if so, how should those be defined? And that's one of the things we have in the RFI. The other thing we wanted to emphasize here is our intent around resetting of the price of the targets. So our current thinking is that we won't reset that target price for 3 years, so that if you won't be held against the savings you achieve in year 1. So if you can realize those in each year. There are 2 things that are exceptions to that. One is we are considering making it a different rule for shifts in place of service. So as we said earlier, we are intending to give conveners credit for shifts in place of service. I think where we're less committed on that is whether you will be able to earn that repeatedly or whether we would only reward increments. So if you move from 50% regulated to 40% regulated in year one and then 30% in year two you would only benefit from 30 to the difference from the 40 to 30. We would have reached the target price. Given the earlier conversation about the challenges in achieving savings in shifts of place of service, I think we're still thinking about whether that really makes sense. Our original thinking is that if you're doing the shift, which is the relatively low-hanging piece of fruit, we aren't sure we want to give that every year. We would only reward incremental, but that's something else certainly we're interested in input on. The other thing is that target prices would be based on when you enter the program. So if you choose not to enter year two, we would establish target prices based on the more recent experience. The commitment to 2019 is for folks entering year one. Folks entering year two, the baseline would go through 2020. But once you're in the program, you're locked in on that 2019 with the exception of the place of service shifts. There's no questions about that. Next slide. So this slide is what we're planning in terms of the data release. So most of what we've been talking about is this first thing. In the summer of 2020, based on a response to the RFA and a potential list of episode initiators, we are planning to put together a file in a simple format of some kind that will have preliminary target prices and lots of those other variables, kind of like the things that were listed, spending by place of service. That would be available at an episode initiator level once folks have responded to the RFA. I think the goal is to get it out within 30 days of getting that level of commitment. It would not have PHI at that point, but we think it would give you enough information to understand the number of episodes and then information around those episodes, and it'll mirror some of the shells used by CMS, and we've already received some input from potential conveners on what that file could look like. That would be phase one of the release. I think what we could probably do prior to that, much quicker, is just expand those tables earlier in this presentation to show you at a statewide level how the spending distributes, and it sounded like that would be useful to people, so I think we could probably get that out within the next couple of weeks. But this file would allow you to see it specific to specific episode initiators. Once folks have signed a participation agreement, which we don't anticipate happening until late in this year, you would then be able to get a CCLF extract of the claims level detail for everyone who has a treatment relationship with those episode initiators in the history, and then you'd be able to get that file on a regular download so you could get new information as new people came into the program. And then in the spring of 2021, there will be a CRISP reporting tool that would allow you to see how you're doing in terms of savings. That won't probably come out until the first episodes begin to complete because it's not relevant until that happens. But that's where you could see, what was my baseline, how am I doing in the completed episodes, what's my risk adjustment looking like, etc. So that tool would be to understand what we're viewing as the performance, and ultimately that would tie into what we're going to tell CMS the payments should be. So I'll stop there. Any questions about that in terms of additional data schedule? All right, next slide. So this is the next steps. I think this is our wrap here. We will be sending out the RFI. I think our goal is to send that out on Monday, but I think certainly early next week. The due date, as Chris said earlier, will be April 17th, so we'll give folks about a month to respond to that. That will include a written summary of all the things we just said about episode design, as well as a separate handout with the CPT trigger codes. It will ask you for input on those CPT trigger codes and other thoughts you have. It will ask for input on the payment windows and methodologies. It will ask for input on the episodes to include in year 2. But it also is going to include a question that basically says, tell us whatever else you think we need to know. So we would like to get input on any of the topics that have been talked about today. And then future EQUIP subgroups will be focused on potential oncology models, the quality measures, and then clearly this methodology and the feedback from the RFI and where things stand. So I'll pause, Chris. I don't know if there's anything else you want to add on the next steps.
So what I would add is just recall everyone that unlike the federal programs, for us, every year is a new year, kind of a restart. So this is all for year 1, trying to figure out year 1 and getting input for year 2. But, there will be a new set of documents for year 2. So this is all kind of focused on year 1. And to that end, with respect to the comments that you provide for the RFI, and I think it would be super helpful if you have a concern, I'll just make up an example, the episode length is too long, then just instead of just pointing out what your concern is, to recommend a specific solution or fix and what the basis for that is. And so if someone wants to propose trying to get an episode only be related to related costs, which again I will tell you I think that's an uphill battle, but I think the thing that is going to give you the greatest chance of success is if you can say, for example, these are the things to specifically include, exclude. Even if you had an appendix that listed all the codes, that would be helpful. I would also say that if you responded and said, to a point that was raised earlier, we are doing this already with a payer, and for multi-payer alignment, this is their approach, and they do it in this way, and to lay that out, I think that would, again, it's no guarantee, but I think that is going to increase the likelihood that kind of comment could be taken into account. And then there was also a question that came over in the comment. It was just to me, so I'll just read it. I think this to William, CRS tool would not refresh until 90 days after the 90-day episode, ?
Yes, that's right. So the CRS tool would only report episodes that have that are complete and then have some reasonable level of run out.
Yeah, so that's all the comments and questions that I have. So curious if anybody else has other.
Are there any other questions, comments, or concerns? This is your kind of last shot to get it out. All right. Go ahead.
Gene, I was just going to add one more thing to what Chris said, and I said this earlier, but I want to sort of say it again to make it clear. As Chris has said, we think it's unlikely we're going to be able to change the definition to carve pieces of the total cost of care out. So I think the more likely path is to define the episodes in a more narrow way that exclude people that are going to be cause you issues. So I think there was an example of people always having screenings for colonoscopy before hip replacements. You could tackle that if you wanted to exclude those by saying, well, anybody who has a hip replacement within 30 days is out of my episode. So I just wanted to circle back to that, as I think that might be a way that is more attractive to tackle.
Yeah, this is Mike. I think, again, in gastroenterology, episodes for the main procedures we're talking about here, upper endoscopy, colonoscopy, if you look at Prometheus definitions of those types of episodes, typical is not any longer than 14 days after the procedure. So if we define those episodes more in line with what typical episode definition is for those episodes, that would make more sense to us. 90 days after a colonoscopy seems unpredictable for us. There's no way. We would have no data on that, so we would have nothing to know. So definition of episodes is important. I wrote down some other questions about maybe understanding some of these definitions on in our specialty, regulated versus unregulated and shifting, but I can probably take those offline. And then actually I had another question about, this is obviously an alternative payment model program. One of the things that gastroenterologists have had trouble doing is moving into alternative payment models to comply with the goal of MACRA and to avoid reporting for MIPS, because if you reach a certain proportion of your services that are within alternative payment models, then there's no longer a requirement to report in MIPS. So how would we be able to calculate whether or not our participation in this program for upper endoscopy, colonoscopy, for Medicare patients, plus whatever else we do with episode of care alternative payment models with commercial payers, how would we be able to know whether or not we can stop reporting MIPS information? Who would be the person to be able to help us calculate that?
So this is where if we say much about federal policy, we get ourselves in trouble. So I think I will punt on that. And I hear your point, and definitely the intent is to open the opportunity to be macrotized, as we call it. But it raises a lot of questions, including the one that you raised about at what point can I stop doing this? And so we're not the ones to answer those questions. But I think in your RFI, if you could list those questions, then maybe that could be an opportunity where we could have CMS weigh in with their own FAQs in response to those.
Fair enough. Obviously, it sounds like there's going to be an opportunity here over the next period of time to raise questions, get answers, and understand before we're signing on the dotted line to commit.
Exactly. And so let me just reiterate in terms of a timeline. You sign on, the convener signs on the dotted line at the end of this year at some point when the participation agreement is signed. So when a convener is responding to the application and saying, here's my list of potential episode initiators, and here's what I'm interested in, and I'm interested in looking at the data, when that data comes back and hopefully a lot of the questions are answered, then at the end of this year, the convener and each of the potential initiators are going to have a decision about, okay, what are we going to do? Are we going to do this thing or not? And so there's, I don't want to say a lot of time, but there's time and several months here to look at data, to get a greater appreciation for how all of these, machinations work. And again, on the one hand, it kind of sucks that we have to build this Rube Goldberg machine to account for the GBR, but the flip side is that, we're aligning with the hospitals, and so we're just trying to make it work and give you guys an opportunity that otherwise isn't going to exist.
Is there any place I could go to read about the calculations and stuff that were done for the GBR and what's defined in there? Because it's certainly a confusing point for me.
So I think in the RFI, we've tried to go into a little bit of detail about this. And William, this makes me think that maybe we should flesh that out a little bit more just so folks are clear about, we're talking about the regulated facility costs, doctors working in the facility. Obviously, well, it's obvious to me, they don't count as part of being regulated. So anyway, we will try to take it another level down into the weeds so that you have a greater appreciation for that.
So we have two more things in the comment. One is a comment. Adam Conway said preliminary QP status is available roughly second quarter of the performance year. And Jennifer from Frederick asked, do you know whether if by defining by CPT removes the concerns of the orthopedic surgeons in EQIP and BPCI around fracture inclusion? maybe that's a question for Dr.
Yeah,
Grasso. I don't know.
Right. Yeah, to take the second one, I don't know. Yes, I would say that might be something that.
Yeah, the CPT codes would be different for fracture care than it would be for routine procedures. So it would have to be review the CPT codes that are inclusive. But
Well, maybe that's something we can think about as we respond to the RFA. Are there any other questions from anybody as we kind of close things out? All right, so I want to make a couple points. If you did not get an email from me, please make sure you reach out to me so I add you to the list because we're sending updates through that. Secondly, Will and Chris have been very, very willing to do specialty specific meetings or subgroups to answer some of those technical questions around your specialty. I'm happy to help set those up for anybody on the call. Sorry. And then the last point I wanted to make was I will be sending something out with a game plan for the next meeting, and I will be sending something out with regards to the RFA as soon as it's available. I don't know, Will and Chris,
RFI.
Did you want to make any closing comments? I'm sorry,
yeah,
RFI.
I'm just clarifying. Yeah, RFI. CMS will publish the RFA later in the spring, but we're at this point just asking for information on the episode design. But yeah, that all sounds good.
Anything else, William?
Gene, this is Mike Weinstein again. So as you said at the very beginning, this was recorded. It'd be great if we can get that, because this is the kind of thing I'd like to share with obviously a couple other people and a couple of our consultants who are the geeky types on analyzing this type of these types of numbers. So if we can get that, then I think we'll be able to form better questions if I get some business heads involved.
We are going to post the recording, and I want to again thank MHA for helping us with this, but we're going to post the recording and the slides on both the MedKai and the CRC website.
Okay. Well, I guess that's all the questions, Gene.
Yep. Well, thank you, everybody. Have a good afternoon and a good weekend.
Great. Thanks, everyone.
Thanks. Bye-bye.
Thank you.